All right, well, welcome everyone. And Anitra, if you want to go ahead and turn your screen share on so that everybody can see our slides. We're delighted to have you join us for the evolution of crisis teams in higher education. One of the things that we've been thinking about a lot as we move forward into this post-COVID hybrid model of care world is figuring out what are our next steps for crisis teams in higher ed. And so we're going to take a few minutes to go through that with you today. We have some really fantastic guests that I'm really excited to introduce you to. Dr. John Dunkel spent 25 years working in counseling and psychological services at Northwestern University, and 15 of those years were as an executive director. He supervised the NU Center for Awareness, Response, and Education. And in 2020, he joined the JED Foundation as the Senior Clinical Director of Knowledge and Advising. So he's since visited over 60 campuses and really has a wealth of knowledge sort of nationally to share today. Dr. Sharika Adams has over 15 years of administrative experience in higher education and student affairs, including serving as Virginia Tech's Associate and Senior Associate Dean of Students from 2007 to 2017. And during that time, she convened the university's care team and supervised the dean's advocacy response team. Dr. Adams is the assistant professor of practice in Virginia Tech's Higher Education and Student Affairs program. And she is published in this Journal of Student Affairs Research and Practice, and her research centers on case management in higher education. And then finally, Dwight Burke has served at Colorado State University for over 37 years, including 13 years as the current director of support and safety assessment. He's helped develop and establish the institution's crisis team, and also currently oversees threat assessment and management, early intervention strategies, and security clearance and other related investigations. So welcome to all of our guests. I'm Dr. Nora Felposh. I'm the medical director at Mantra Health. I'm a psychiatrist with a deep background in college mental health and crisis intervention and management for college students. And I will be leading this conversation. If anyone has any questions, please feel free to use the Q&A at the bottom of your screen, and we'll try to answer questions either during the presentation or some we may save for the end, just kind of depending on our timing. Yeah, so welcome everybody. Let's jump right in and get started. So today we're going to be talking about crisis management, kind of what's changed, what the future of hybrid care looks like in crisis prevention care. A crisis can be widely defined, right? But for the purposes of this discussion, we're really going to focus on mental health crisis, how to address them at an institutional level, and what our panelists have learned about that in their deep experience across the years in a university and higher ed. So we're going to start out here with, we're going to kind of why is this topic so prevalent? How has care management evolved since 2007? And then we're going to kind of shift into talking about how institutions build systems of communication between relevant stakeholders, and a little bit about what hybrid care, even third-party care, needs to be thinking about, or what institutions need to be thinking about as we start to bring hybrid and internet-based care to students and to campuses really nationwide. So Shrika, let's start with you. You worked at Virginia Tech for a long time, and you were part of creating their response team to crisis, and in turn shaping the national response to crisis overall. Can you kind of spend a few minutes walking us through the origins of crisis teams in higher education? And you can refer to the slide as well if that's useful.
Absolutely, and thank you. It's good to be here, and I'll say I was still at Virginia Tech. Let's not give my job away just yet. No, it's certainly good again to be with you all. I think probably the easiest way for me to approach it is just kind of share kind of how some transitions have occurred over the scope of the years. One of my observations and things that I've noted is crisis management teams have evolved on campuses at different points in times. So there's not necessarily a starting point for each of these different changes, just kind of depends on where you are, certainly across the country. But if we think collectively, and I'm going to look at notes also, If we think collectively, certainly we start in 2007 with the April 16th shootings at Virginia Tech. And so we know that the landscape changed almost 16 years ago in a week or so. But with regard to things that have been like put in place since that time, there have been different organizations that have started, and so I'll highlight those super quick about, NABITA, which is the National Association of Behavioral Intervention and Threat Assessment, which on the slide was started in 2009. You'll also note HECMA, the Higher Education Case Managers Association, which began in 2011. There's also been things like increased trainings over the scope of years from the Department of Criminal Justice. If you're in student affairs, ACPA and NASPA have added knowledge communities. So if you think over the course of time, increased trainings have occurred. In addition, there's been different legislative acts and things that have occurred. And I believe we're going to talk about that a little bit more specifically in the course of our presentation. But I'll lift up in particular changes to the Clery Act, the 1990 Clery Act, which post 2007 folded in and added timely warnings and notifications. And so that is something else that has happened. And then more specifically, formalization and the public nature of crisis management occurred, again, depending on where you are across the country, but over time. So the establishment of care teams and behavioral intervention teams and all of those things that, all of those teams and multi-departmental groups, which help focus on mental health and crisis management in particular.
Got it.
Yeah.
Dwight, later in the webinar, we're going to talk a little bit about CSU's crisis team, but I'm wondering, I'd just love to get your perspective on kind of what's changed or evolved in recent years, what you're seeing as sort of the cutting edge on campus of what these teams are continuing to grow and look like.
Yeah, sure. I think from my perspective, most of the early iterations of crisis teams that we saw were really focused on students. Mm-hmm. And as a result, most of this work got housed within student affairs. And I think more and more as kind of threat assessment and management has become more center practice, we're recognizing that this is a centralized issue to institutions and not a student issue. So now we see institutions kind of scrambling on how to handle their faculty staff concerns or concerns about people outside of the institution that are creating some kind of issues for the institution. So I think there's a lot of structural questions being asked about these teams. Certainly the care teams tend to be very student focused, but as mental health concerns continue to rise, we see this rise of faculty staff concerns on how do we provide that same level of support there. And that just creates a real structural question for institutions on how do they house this and how do they centralize this work when it has been so ingrained in the student affairs field.
Mm-hmm. It sounds like it really becomes a community-wide issue then, as opposed to just being focused on one area of campus or on students alone.
Yeah, I think that's right. And of course, student affairs is so often the first to the problem and the first to the game. And now you're seeing a lot of them say, but we're not here to do faculty, staff, or community level work. And so that's where those structural questions come in.
Got it. That sort of siloing of different areas of campus. John, both Virginia and Illinois have established laws around threat assessment teams, but many states haven't. Can you talk a little bit about policy funding, what's needed to build and enact these cross-campus systems? Because I know sometimes the lawmakers, I think, are very well-meaning, and they'll step in and create, legal guidelines or legal mandates when the campuses are kind of left scrambling to catch up. And I'm wondering, John, what your thoughts are on that specifically.
Sure. I mean, I think that gets at like unfunded mandates, as they call that. How are we going to create these teams and do the work that needs to be done. I think creating written policies and procedures around this. I lived in the state of Illinois, obviously, where I worked, and we had to, by law, to create an emergency response. So it's much broader, and a threat assessment team was one piece of it. And so it really involves doing the research around what are the best practices around it. Before 2007, the tragedies in 2007 at Virginia Tech, and then Northern Illinois not too long after, there were teams like this, not a lot. They proliferated, and so getting into creating and being intentional about who needs to be at the table. We mentioned students had been the focus, but as Dwight said, faculty and staff are also are people that we need to think about in case they might be on what they call in the field a pathway to violence, and people not even affiliated with the institution. So teams need to be thinking about how to monitor, assess, intervene when necessary. I think training is really important with whatever is set up. This is not an easy task to do. There's so much to think about. Social media adds a whole nother layer to it that can be helpful sometimes, and sometimes this can be a lot to follow. How do you document? That's another thing to think about. How do you document this information? After the tragedies at Virginia Tech and Northern Illinois, there's a lot of confusion about FERPA. What does it cover? What can you communicate? What you can't? And I think we've gotten some more clarification on it, although there's still some confusion among some. But documentation is really important, and also tracking the data so you can start to see if there's trends. I think that's really critical. And doing tabletop exercises where you can, so you can practice, so you know who plays what role on the team, and how it's going to convene, and how it's going to process cases, et cetera.
We'll talk a little bit later about, third-party telehealth and thinking the way through that, or even hybrid care, but how you get those folks that may not be, sitting on campus involved in this, and making sure that all of those pieces are feeding into one unique whole, for sure. Let's see the next slide. One of the things that Dwight, that you mentioned, is the fact that this is really a community-wide concern, right? Not just something that affects students. And one of the things that we think a lot about is, social determinants of health, right? And the idea that they're really basic needs that go beyond just mental health. And I think it's really, really critical to be able to have that built into your program of response, and that built into for all of your providers, not just the ones that are on campus. Shrika, I know case management is a vital component of crisis prevention, can help remove barriers that exist for many students getting into mental health care. Can you kind of talk us through the correlation between social determinants of health and their effects on students in distress, and how that weighs into the discussion?
Yes, absolutely. I mean, and I think you hit the nail on the head. I mean, fundamentally, I think in order to, mitigate risk and increase academic persistence, you have to alleviate and work within students and community members that have issues of basic needs. And so, when I think about social determinants, I think back to like Maslow's hierarchy. So all of our social scientists out there, right? When you think about kind of the bottom of the hierarchy, some of the basic needs are that of food and shelter. And so when you think about your college community, we're talking about food insecurity and either homelessness or housing insecurity. And if those things are present, or if safety is threatened, for example, that's the next layer, it'll certainly be difficult to do well. So that's kind of how they overlap. I think some recent data that I saw said that about a third of students experience some level of food insecurity, and 14% experience some level of homelessness. And there's also levels of like hidden homelessness. So when you think about those two things in particular, there's research that has shown that with food insecurity and housing insecurity, that there's an increased risk for psychological distress, right? Because you're stressed out if you have to choose between food and tuition, or between bills and books and those sorts of things. And so when you think about case management in particular, and working to alleviate crisis, you're thinking about and addressing some of those basic needs on the ground of how do we help students get through the next couple of days, and alleviate some pretty immediate needs.
Absolutely. And I think when you're talking about universities that also have online students, I know that sometimes the hybrid models of care address those students specifically, right? Because they're not on campus, can't come in for care. But it's important to be thinking about the communities in which those students are embedded, and how are you prepared to help get those students connected to resources at home where they are as well. We have to kind of start to think much more globally, I think, in terms of basic needs than just what is available right on campus.
Exactly.
So comments, Dwight or John, before we move on a little bit to talking about the comprehensive approach, and John, your recommendations around that.
Sure. So if we can go to the next slide.
The next slide, sure.
Yeah, please. So at the JED Foundation, we help high schools and colleges develop strategic plans around mental health and suicide prevention based on a comprehensive public health approach, because we know that just focusing on one area or one department or one angle is not going to really, help address the issues at the level that they need to be addressed. So this is our comprehensive approach that was created about over 20 years ago. It was based on a model that was created by the United States Air Force. It was adapted. And as you can see from this graphic, it's surrounded by two circles: strategic planning and equitable implementation. Strategic planning meaning that we help schools to be intentional about how they address the various levels of the comprehensive approach by using data, by looking at best practices and that types of thing. And it's all surrounded by equitable implementation. So everything that we suggest about programs, services, policies, procedures are suggested and recommended through a lens of equitable implementation. How are we reaching the most vulnerable students, the students who are marginalized, minoritized, so that we create a safety net that will actually help them and that help the whole campus? And then within the circle are 7 what we call domain areas, and each area we helped campuses think about ways they can address mental health and suicide prevention through them. First, developing life skills. How do we teach skills upstream, as they say, to give students skills to hopefully avoid a mental health crisis or a suicide crisis? The next domain is promoting social connectedness. We know that loneliness can be a risk factor for mental health crisis and even suicidal ideation. And so how do we help schools think about how students are connecting, ways that they can do that? Identifying students at risk. This is really, I think, touches really on what we're talking about today. What are the mechanisms in place? So if there's someone who's of concern, a student, how do we identify them? How do we educate the community to do it? And how do we get them to know how to get them to where they need to go? Increasing help-seeking behavior, that's really important. Help-seeking behavior can vary along a lot of different demographic dimensions. What are the mental health services and substance misuse services that you're offering to your student body? What are your crisis management procedures? That comes to bear on this topic as well, and making sure that that's clear. And then finally, promoting means safety. We know that when suicidal act can be a very impulsive act. So if you limit access to means that could be potentially lethal, that can go a long way in hopefully preventing a crisis. So this approach is really broad. And without doing it justice in just a few minutes, we walk through every steps of these, and developing care teams, behavioral intervention teams, threat assessment teams is one piece of that. And when we do that, what we're hoping we're doing is we're helping campuses create what we call a community of care, which is the next slide.
Got it. So before we move on, I think two quick questions and a quick comment. I think this is one of those things where, as a third-party telehealth, we really think a lot about how does that telehealth company fit into this, right? How do we make sure that the right policies and protocols are in place to manage crisis within that system, and then that also tap into the resources on campus? And how do we make sure that if there's information coming to any provider in the mental health space, and this is true whether you're talking about hybrid care or in person, how do those feedback in a way that's both HIPAA compliant, but that also keeps that information flowing, and keeps that team sort of aware of critical concerns on campus? Dwight, you had mentioned that faculty and staff play a major role in crisis management, especially in assessing and reporting risk. I'm wondering how you've incorporated faculty and staff into the crisis management care at CSU specifically, and sort of a demonstration of this comprehensive approach.
I think, the first is to recognize that the roles of each individual will vary greatly, right? So it really comes around to the individual's personal ability and desire to have some role versus having a way to just report their concern and kind of be a one and done. And so, when we think of that faculty staff model, we've got people on all ends of that spectrum. So recognizing that not everyone's equipped or appropriate to be a resource for someone experiencing early levels of crisis, but then getting them to choose that level of involvement with follow-up trainings. So some of the ones that come to mind right off the top of my head are like notice and respond, or mental health first aid, some of those types of training that those that have the interest could get that additional level of training where they can take those early steps, the listen, the care, and refer kind of work, but then knowing that that's kind of where their lane ends. And then I think importantly is recognizing that as we look through the years, what we've seen here is a shift in faculty in particular's attitudes around wanting to be involved and wanting to report. We're seeing faculty much more interested. And, an example for us is our Tell Someone program, which I'll talk about a little more later, but that's our referral service for anybody in the community to report anybody that's got concerning behaviors. 77% of our reports come in from faculty and staff today, versus, years ago, we were just barely scraping reports out of faculty and staff. And so really it's just getting out there, empowering them that they get to choose where their level of involvement is, making sure they know what those guardrails are around their involvement, setting those boundaries, and then involving them as appropriate through those systems.
I like that idea of giving faculty options too, because certainly, John, I'm sure in your work you hear from faculty and staff who have concerns about, I am noticing something's going wrong, but I don't know what to do about it. I don't know who to reach out to next, which leads us to this, how do you sort of establish a community of care? If you bring us to the next slide, John, do you want to take a few minutes to talk us through this as well?
Sure. So I always get asked, often get asked, what do you mean by community of care? And, this is a simple, but I think good graphic to just get at the essentials of what a community of care is. And keep in mind that what we're trying to do is we're trying to create a support net for students on our campuses. And there are different key constituents on campus, and you can see them in the outer bubbles. And I realize that some campuses may or may not have some of these roles and may call them something different. But the idea is that we're trying to work together. Think of this as like a family tree for your campus. You could create one of these for your campus and say, who are the key parties on our campus who are part of this care? And where those lines that connect the bubbles, think of them as like relationships. They're the basis, they're trust, mutual respect, clear communication, and understanding about what each roles are and what your responsibilities are. And the more of those you have and the thicker they are, the fewer cracks there are for students to fall through. We've heard that expression before. So I think of a community care, I think of this, and that it's like a net. And we're trying to form a net so that fewer and fewer students fall through the cracks. And that comes with building those relationships, bringing down those silos. If you don't know somebody, draw a line to that person you don't know so you can get to know them.
Absolutely. Curious if you've seen campuses talking about hybrid models of care, providers who might be far away from where students are. How does that fit into this sort of community of care net, or is that yet to be developed?
I think, whatever they have in terms of hybrid care, they need campuses. What I would recommend is think about how that communication happens. So these nets, these strings that are attaching them stay together. And that takes work. This isn't something that you just do when you're done. It's something that takes time. It takes relationship building. There's also turnover. We know there's been a lot of turnover in higher ed, particularly in student affairs. And so that takes constant turnover. There's often turnover, so you have to constant vigilance about who's in what role and making sure that they're educated about that. Faculty you mentioned earlier. That's one of the number one things I hear about on campus visits, about the role of faculty. And I know for sure from my own experience and also listening to on campuses that faculty do care a great deal. Sometimes they just don't have the language or the skills or the knowledge to know what to do, but they're yearning for it. So I think that as a part of community care, those relationships take work, especially with the high turnover.
Absolutely. So Dwight, let's shift to you now for a minute. Over time, CSU's put a lot of investment and time, really, in resources into building a collaborative threat assessment team on campus. Can you share what this evolution's looked like and the structure of the current team? Kind of walk us through what CSU has been doing over the years and where they are now, and even where they're going in the future.
Sure. So I might start with a little bit of a jealousy statement to some of my colleagues and peers out there. Is we were able to submit a series of proposals over about 7 years, 4 different proposals up through our administration and ultimately to our board, that resulted in about $2.5 million of funding to be distributed to a number of departments as part of this collaborative multidisciplinary approach. And that was expansion funding. And so the very first one was enough years ago when many of us still thought we might be able to hire our way out of the problem with expanding some counseling services. And so, we added staff that way. We increased my office's ability to triage and do centralized screening and referrals. We added additional student case management levels of support. So that's kind of the early part that led to now a pretty comprehensive system where I think our teams in particular, we have a combined care/threat assessment team, which I think some of my colleagues would hold up a pause button and say, wait a minute, that's not necessarily the best thing. But the caveat I would put in there is that we have full-time staff doing triage that does probably 80% of what most care teams do without needing that full team structure, right? So it's still getting triaged in that initial individualized review, but referred without it necessarily rising to have to come to the whole team. And so then our teams are split along student related versus faculty, staff, and outside entity related groups. So those cases that reach a threshold, fairly high threshold of behavior that causes those teams to be, or those individuals to be staffed, then get that comprehensive multidisciplinary staffing, which is pretty common through many of our institutions. I think it's important to note that we, as part of that funding expansion I was talking about, we created this intensive treatment team on campus, which we call the I-team. And that team allows us to keep students that are in a higher level of need. They're getting intensive level of treatment support while they're on campus, and then we're retaining them through that process. And that's worked out really well for us. Our retention and persistence numbers bear out that was well worth the endeavor. But it's a treatment intensive and funding intensive service to be able to have psychiatry and therapy models and medical case management all in one group, providing that intense treatment for those students who were hospitalized, maybe coming out post-hospitalization, or presenting behaviors that are of substantial enough risk where we're going to mandate that level of care.
Absolutely. So I had the good fortune to be kind of part of that team and help to build that team. And it was a lot of fun and really interesting. And I think that was one of the things that often came up was, gosh, you're investing a lot in a small number of students. And I think our response was, first of all, to point towards Daniel Eisenberg's research and say, even a small number of retained students is actually quite a bit of tuition. And these are the students that are most likely to harm themselves or even potentially harm others. And so if we can keep them in and keep them close, as opposed to kind of pushing them out and getting them off campus and off of our radar, we're actually probably going to save a good bit of resources in the long run and potentially minimize crisis in the long run as well. Dwight, are you done kind of walking through here? Can I ask you a few questions, or did you have a few more things you wanted to cover for us before I jump in?
No, go ahead. I might just add that I think most of us recognize that our professionals on campus are generally the best equipped to help our students. And most of us have experienced community level resources that are set on those community level standards of imminency. And that's usually woefully equipped to get our students stable and ready to return to a higher education environment. So I think just that philosophy of recognizing that we're best equipped, and yes, it's a smaller number of students with a high level of cost, but it is the right, I think, can bear out to be the right thing to do if you're a large enough entity that can get that level of resource when you do the data to show that the retention factors probably do make it worthwhile.
Yeah. And I think the other thinking behind this from a mental health perspective as well is that these are the students that are most likely to be at the highest risk. And so, if you move them off campus or out of care right at that moment when they're probably most in need of that level of support and that level of intervention, it can be difficult on the student, and you can have poor outcomes ultimately, especially if you have students going back to rural areas or places where they're waiting months or longer to get into that intensive level of care, or there isn't that intensive level of care available. Curious about what role that team plays in risk and suicide assessments specifically.
Sure. Yeah. So when anybody that gets referred for that initial intake screening, so part of our individualized review is that if we need more information, which most of the time we do to make a decision, we're going to require that assessment. And that assessment then brings in that suicide risk. It's a very comprehensive screening process. And then for us, our student case management creates a very frequent kind of touch point for students, because a lot of times as schedules get busy and these appointments fill up, you may be talking 1 to 2 weeks of time post-hospitalization until some of these assessments can occur. And so I think it's really important that whatever system you have, you've got those regular touch points so that you've got that constant information coming back, because it's a really critical time. I think that 1 to 2 weeks post-hospitalization.
Yeah, for sure. And even sometimes going out for the mental health beyond that as well can be critical. We have a question coming in. How do you mandate that level of care? I know this is something that we struggled with a lot, right? At CSU, had kind of thinking our way through this, but I'd like to hear your input on this, and then maybe Sharika, given your your experience on campus, maybe comment as well on how do we loop these students in when they may not may not be standing there waiting to sign up for mental health care for university involvement.
Yeah, I might just jump in quick. I think one of the references we have at the end of this is the JED guide to balancing mental health and safety. And I think that guide's a good starting point on recognizing that when you we're not tying any mandates to mental health, we're tying any mandates to behaviors. And then as we need to take reasonable actions to mitigate those behaviors, one of those actions may include some kind of round of treatment or therapy, where we're then getting information back that somebody's reached a point of stability. So I think from that standpoint, that's how you have to tie it for any mandates that you're doing.
Mm-hmm.
Yes, I would echo what Dwight said to definitely address behavioral concerns versus saying that you're mandating for mental health concerns and reasons. And very similar, I think, what we did at Tech when we developed mandatory assessments was, it was a one-time visit at a minimum, visit or connection to counseling and triage services. So, there has to be some carrot connection, motivation, if you will. And sometimes that was, administrative in the sense of there'd be a hold on an account or something like that. But also it could be relational, where, an RA or community member could directly walk a student to counseling at the time, if they were had an area of concern or distress.
John, it sounds like there's the JED Foundation has created some guidelines around this. Do you have any thoughts or ideas to add as well as we're talking this through?
Sure. And so the document was actually created by the Higher Education Mental Health Alliance, HEMA, of which JED is a member organization. And it's available. I think we have the link here and on our website. We also talked to a lot of campuses during visits about, how they intervene with students who might be of concern. And just to underscore, I think something that was said earlier, but I just want to say it maybe a slightly different way. What I see a lot in our visits when we go, there's usually like 2 or 3 types of teams. There's the threat assessment team, or what some people call behavioral intervention team. And then there's something just below that, which sometimes is called student of concern, student care team, whatever you want to call it. And those are that's a bigger radar because there's a lot more concerns out there for students who might be, distressed in some way. But the threat assessment team usually is a much smaller group. And, getting the referrals to them usually involves bringing the threat assessment team together. But the student of concerns team is a much lower level. A lot of counseling centers will often do initial assessments if a student is referred, if there's concern about them, to determine if there's any safety risk, if there could benefit from treatment of some sort, whether it's on campus or off. But threat assessment teams, when there's something serious in terms of a threat to the community, that usually involves perhaps a forensic evaluation, which is usually done off campus, or things like that. But I just wanted to make sure I distinguish between those two. There's even 3. One campus had 3 different types of teams. I can't remember what the third one was, but there's different levels of teams depending upon the concern.
Mm-hmm. I think, Sharika, did you have a comment on that?
Yeah, I just wanted to kind of jump in and reiterate what John said. I would add though that sometimes and on some campuses, there are there can be different levels between the threat assessment and what might be the care team, student and concern team, but they're also complementary and handle different types of situations, although they might not be, a student that might have an issue on a student of concern team might not pose a threat, but the situation, for example, might be as significant. And so for both teams, for all groups, I would just add that having a multi-departmental approach to form that community of care that John was talking about, we call it a nexus, right? You're going to form that nexus of care and connect those dots tightly. And that's why there might be overlap, for example, on some of those groups to address those very different needs. So, at Tech, there was, a time at which there might be a counseling or mandatory referral coming from what was our care team versus threat assessment. And so those teams work collaboratively. And for example, during my time, I overlapped on both to help kind of create that nexus of care.
Mm-hmm. It's an interesting comment, and Dwight, I'm curious to hear what your thoughts are, because I think one of the things that's quite nice about the CSU system is it seems like there's one centralized place that everything kind of filters into and then goes back out from there. And so instead of having, siloed different folks on campus, everybody kind of comes together in one, and they're also taking the burden somewhat off of the counseling center, so that the counseling center may be part of providing the clinical recommendations and care, but they're not necessarily the ones that have to monitor what's going on campus quite as that there's really a dedicated team for that. Dwight, I'm just curious what your thoughts are on that.
Yeah, I think, that's a critical point, is whatever the system is making sure there is one central repository that this information is accessible in, and so, a third team, John, that I've seen, and we have one, is the complex needs team, right? So students that have very high level of needs, but they're not necessarily concern or risk. They're just those complex needs. But some of them then trickle into the care team or trickle up to the threat assessment and management team. And so having one place where there's all that information is accessible. That's what is, for our system, that's what our office is that one central repository, so that everything comes in. We use the hub and spoked wheel model. We're that hub. So we may not deal with it, but everything comes in and back out through that one central place. So there's the ability to connect all those dots.
Got it. One of the lots of the questions and the concerns that are coming up is, these are recommendations that all size campuses with all different types of resources are trying to figure out how to implement based on the resources that they have. I'm wondering if each of our panelists really could comment on, funding. How do you do this? Dwight, it sounds like at CSU you were successful in getting the administration to invest, and the administration obviously had the money there to build into these programs. But I'm curious, how do you approach that if you have a campus where maybe this isn't, you're trying to figure out how to get this prioritized?
My first reaction to that question, Nora, is, what are the values and what are the stated priorities of the institution? That should flow from the values. And it would seem to me that the safety of the community would be the top priority, I would think. And from that should be prioritizing, resources and programming and policies around that. Now, the question is, on campuses where, enrollment is dwindling and they're enrollment driven, that becomes more tricky. Are there grants out there? Are there other types of things? But it starts to me with the values. What is the value, and is this a priority for the campus? And in most campuses, it is.
Mm-hmm.
I might jump in. I agree 100%. And I think it's a lot of trust building and a little bit of salesmanship. And we're selling a philosophy, right? We're selling a philosophy that early identification, early and prevention work equates to safety. And that philosophy is supported by research. It's supported by a lot of best practices. And you have to, I think, really connect that philosophy of the well-being of our campus has those direct impacts on, makes us a safer campus. It makes us a more attractive campus. It brings in more money. It brings in better ratings. It's tied to so much, and you have to get out and make that case.
I think that's an important point too, is that, I think parents and students are starting to ask, what do you have on campus? What's available? What kind of resources do you have? And I think it is actually a value add to be able to have a clear way to answer that question and even to market that question. Sharika, you look like you were getting ready to jump in.
Yeah, I was going to say yes to what John and Dwight have said, and I'll also say, numbers talk, right? So I'm a big assessment fan. And when you talk about, adding staff, I think, and I'm scanning the chat where we talk about student to administrative ratios. I think when it comes to threat management, crisis management, case management, those numbers are still, significantly high across campus. But if you can, or my recommendation would be, if you can start to break down, what number of students folks are seeing over the course of the semester and what issues, you can start to throw numbers and data behind those funding requests, in addition to tying that into the philosophy and values. I think that goes a long way. And I see this 1 to 1,500 student body ratio with the Case Managers Association, with HECMA. Those numbers are also higher that I've seen. So there needs to be significant and increased funding behind these things.
For sure. That's something that we've talked a lot about as we develop the process of overseeing students on various campuses. How do you create a visual so that the campus can see exactly what's being seen on a day-to-day level? It's been my experience when working with universities that the EHR and other things are not often set up well to quickly get your finger on those numbers and have them represented in a way that you can almost see them day to day. And so when we were developing out our dashboard for schools, that's one of the things we thought about is, as a director, as someone on campus, if I wanted to get an overall picture of what is going on with students on my campus, I would be able to get that kind of at the click of a button. And my hope is that as we continue to develop that, we can start to share some of the best practices around that and be able to build some of those systems in, so that folks on college campuses can quickly see and can share between themselves too. I think there's also some question of trying to create an open conversation between campuses, which I think, John, is partly what Jed is doing, to try to figure out what are the numbers. Like, can we share this? Can we figure out what works, what doesn't work, and how do we get more efficient in dealing with those sorts of things? We have a ton of more questions. I'm going to just start jumping in here and asking the ones that are coming in most often. So here's something we haven't really discussed in depth. Who's involved in an emergency response team? And, are police always called, or how do you address that? And I know that among this group, we've talked earlier about, addressing students of color and the whole policing issue. And like, can get very sticky and complicated. I do think there may be some ways that these systems can be built to try to insulate or alleviate some of that concern. Dwight, I'm going to pick on you for just a minute here. I'm curious how CSU has thought about policing on campus and specifically an emergency response. How do you make sure that your team is responding in a way that's going to be most effective and most safe for students?
Yeah, I think, like many of our peers, we've had lots of discussions about what is the appropriate level of emergency response. And so for us, we've implemented a co-responder model that launched last year, where we've got that mental health professional that is going out with police response. And so it's a very tricky situation to try to figure out how to take police completely out of that picture, because I don't know how you do that when you don't know if a scene is safe or if there's firearms on site and all of those issues that come up on that emergency kind of mental health call. But once that initial stuff can be done and you can get law enforcement in the back seat and that mental health professional in the front seat, in the field, before there's handcuffs and transports to the hospital and all of that, I think we have much better results. And so just thinking creatively, not everybody's going to be able to do a co-responder model, but a lot of communities have co-responders, or a lot of mental health services have mobile teams. So really it's back to having these conversations with your community level resources and your university level resources, and trying to build those bridges to get those systems. Because I mean, for most of our students, the traditional emergency mental health response is not a positive experience and does not result in great outcomes. Yeah. So trying to think of it differently, I think, is an important thing for each area.
Yeah. Critical. And I think that, you know, I just would nudge people, since we're, you know, talking about sort of evolution of care as well, to think about how does this happen when students are not on campus? How does this happen when providers interacting with students are not with students? And really thinking that process through to make sure that those students that are accessing that care have equity to the students who are right on campus, where you know the resources, or where even a counselor could walk a student from an office somewhere else, or could accompany them. John, are there overarching guidelines as far as this question that you could weigh in on, or what are your thoughts here?
So I think so it depends on what the emergency is first. I think that's the first thing. And if it's situations where you're concerned about a student possibly being suicidal, you know, the mental health professionals are brought in. Typically, we're seeing more of that on campuses. So Dwight, that's good to hear about that. And getting the students, if they need to go to the hospital, that's the question. And there's a lot of different ways to sort of think about it. Now, keep in mind that sending someone to the hospital, especially if it's involuntary, the laws vary state to state. So you may have no choice. You know, it may need to be the police, or may need to be an ambulance. An ambulance, of course, would incur a charge that it might, the students and their families will not be able to pay necessarily. So I think thinking through, you know, how you're going to intervene, that's why these relationships are really critical. So I worked on a campus where we had university police. I built relationships with them, or our team did, and that was critical, because that went a long way in helping to contain situations that if we didn't have that, I think it would have been a lot worse. So really building out those relationships, if you do have campus police, if you do have, you know, other types of entities on campus that can help in those situations, I think that's a big one, because you don't want to be doing that in the midst of a crisis situation.
Mm-hmm. Sharika, what are your thoughts and your experience on this?
Get back to my mute button. And I can't remember who said it, if it was John or Dwight, but really utilizing, and my recommendation is that community partnership approach. You know, lots of times it might not even be, you know, an RA or a housing member, for example, that might intervene with the student, particularly if there's police involvement. It might be an organizational advisor. And, you know, I think to, you know, maybe even fraternity and sorority life, it might be, you know, an alum or a Greek advisor, maybe just having, being able to have an advocate present in addition to whomever needs to respond, I think goes a long way for helping folks get the assistance that they need. So I think there need to be conversations around, you know, I know we talk about, you know, privacy and FERPA and those sorts of things, but that needs to be weighed against what's in the best interest of the student and what can get them to on the path to health.
For sure. We're getting close to the end, but I'm going to grab one more question. This has come in from several different folks, and that is small campuses with few to no resources. Are there? What's the first step if you could just pick a few things to invest in, if you really have that sort of limited sort of team, let's say they don't have case managers, or let's say they don't, have an extensive counseling center. Are there recommendations that are specific to those types of situations?
Is this in relationship to developing like a behavioral intervention team, or?
I think yes. Yeah.
Okay. Yeah, because there was another question in the chat I saw, is how many people should be on it? I think it really depends. It depends on what the local resources are in the community that might be able to support. Doing benchmarking with other types of schools, I think important. I don't have a magical answer for the small schools, but I will say about the size of it. It really depends on what the focus of it is. If you're going to be monitoring students, faculty, and staff, and those not affiliated, you might need more people. You might need human resources, for example, a faculty, a provost office representative. But being clear about who's going to bring that together, those are things that had to be considered as well, about who leads the team. And that's a serious question, because there's there's implications for, let's say it's a counseling center director. Well, a counseling center director may be put in a conflict of interest if they're asked to lead the team. So there's lots more to it, but I don't have a magical answer for the small teams, other than doing some benchmarking with other schools and seeing what the community resources are, and think about who are the team members that could come together. There's lots of models out there.
Mm-hmm.
Excuse me, I was going to add, organizationally and institutionally, small campuses, administrators in particular, typically have to wear a lot of hats. And so in that, practical sense, I would think about, are there automatically places or individuals where there are other duties as assigned, that some of those responsibilities might include some level of crisis management? And if you had to start kind of day one, like find those 3 or 4 people, and then maybe build out. And that, that multi-departmental scope doesn't have to be 15 people. You can start with those 2 or 3, someone from academics, somebody perhaps clinical, and maybe even, as John was suggesting, a town gown representative, somebody where you can work to form collaborative partnerships or even MOUs, and begin to, put that work out in the community to build those university partnerships.
Mm-hmm. It sounds like that would apply then to the community college situation as well. We're getting really close to the end, and we are going to keep right up to the bitter end, but I want to just remind everybody, just as a final thing before we'll jump on and do one more question, that we're going to share the slides, we're going to share the recording and a transcript afterwards, and we will work hard. We have a lot of questions, so we're going to work hard to try to get as much information back to the folks that are attending as well, and get these these answered as well. So there's a question here about, how do RAs help support this team, or how do you kind of bring in other folks on campus to help support the team?
I might just offer briefly if you do a comprehensive review of your services available on campus, so everything from your residence life community to your financial aid office, and you kind of plot them out on a continuum on, are they doing brief intervention work? Are they capable of doing a little more thorough work? And you look at that continuum and you identify the gaps that you have within those services. You're bringing people into that team that are representing folks along that continuum, but at the same time, for those smaller schools, you're looking to them as your resources then to help expand your service when you can't get the funding or the additional resources to expand. So it really kind of starts with that needs assessment, that what do we have available? What are our needs? What's that gap analysis? And then I would point back to the things that John went through on creating that kind of comprehensive analysis, and that community of care is really the starting point. And then that's where you go forth and argue, who do we need to bring in to expand and to get the proper representation, or how do we make our ask to increase for funding because of those gaps?
Mm-hmm.
And one thing I would add, though, the caveat around RAs, because I hear this all the time in my visits, RAs are students too, and they are really taking on a lot and containing a lot. And so I would just encourage, if RAs are going to be involved, to really think carefully, because I'm hearing it that they are just containing a lot. In some cases, supporting students probably longer than they should. For whatever reason. And so I would just say that caution and think about RA involvement.
Yeah, absolutely. So we're at the end of our time. I think we could talk for another 2 hours pretty easily. I wanted to thank all of our panelists and remind the folks that are attending that we are bringing these panelists back together again to put out a white paper in the later spring, early summer. And so excited to be able to share that and hopefully to address some of the things that we didn't get to today in that white paper as well. So thanks for your attendance and thanks John, Sharika, and Dwight for working with us and really sort of bringing this forward into the national conversation and helping us all to think about what our next steps are. So take care, everybody, and thanks for joining.
Thank you.